The August MEC Minute is on LVADs, and this is a topic that we discussed about 3 years ago, but I've had several questions from our providers, so I saw it as an opportunity to review the subject again. So an LVAD really is an abbreviation for left ventricular assist device. These are mechanical pumps that are surgically implanted in the chest and that help patients who have significant congestive heart failure or advanced heart disease where the heart as a pump just isn't functioning adequately to maintain life in the patient. These patients have pumps in place that are continually running. These are non-pulsatile devices, so it's just like a pump in your car or on the fire engine. These pumps just continue to pump, and you will not feel a pulse. Now, some patients will have a little bit of a pulse simply because they've got enough cardiac activity to move blood, and the pump is then there just to augment or supplement blood flow that the heart is able to produce. We don't look for systolic and diastolic pressures on these patients. We look for a mean arterial pressure, which is really found best by using a Doppler device. And a normal mean arterial pressure is between 60 and 80, and that's our goal for patients with LVADs in place. Typically, these devices have two power connections that go to the power controller and to the pump. And for you, if you have to transport a patient, typically these patients will be using battery power to run the controller and to run the pump. These are the patients that you typically see wearing a vest with a battery in pockets that are in the front, and the batteries are then hooked up to the device. And generally, these patients have a Driveline that comes out of the abdominal wall that connects to the controller. The controller is the device that manages the pump. It tells it how fast to go and so on. If we disconnect the controller from the pump will stop. So that's kind of like a quick, brief summary on what an LVAD is. I'm going to talk today about LVADs in general. I do have some graphics that have to do with specific devices, the HeartMate 2 and 3. These seem to be the devices we most commonly identify in the community. However, other devices may be present depending on the facility or center that places the device and the specific needs to the patient. I found this online, which is an EMS guide to LVADs. It is a app, or not an app, it's a PDF that you could put on your phone or put on your tablet. And it's available via the link that I have there, and it's something that you can use because it's got the devices that are currently in use in the United States, and it gives you information on each individual device and how you problem solve. So if we talk about LVADs, why do we use them? Well, we know the patient has heart failure, we know their cardiac output is inadequate, but there are really two reasons why we would place a device. One is to bridge the patient until they're receiving a heart transplant. That's called a bridge candidate or bridge therapy. So this is placed, the LVAD is placed with the intent of it being a temporary device until the patient has a donor for heart. So that's bridge therapy. What we're seeing more and more, however, is destination therapy. So destination therapy means we're putting the patient on an LVAD with no expectation that they're going to receive a heart transplant. So when we first started using LVADs, they were really more as bridge devices where patients received the device until they had a donor available or donor heart available for transplant. More and more now, we're seeing patients who are receiving destination therapy. They do not qualify for a heart transplant for whatever reason, and this device is going to be with them until they die. So that is destination therapy, and it is now more common that patients receive a device as part of destination therapy rather than as a bridging therapy until transplant. So just a couple devices that you may see, the HeartMate 2 and the HeartMate 3. All devices are generally very similar. You have a pump that is in place that takes blood out of the left ventricle and then puts it through the pump, and then it is expelled into the aorta so that there's this ongoing infusion of blood, this ongoing circuit of blood from the left ventricle to the aorta. The pump tends to be in line. External to the patient is a controller. The controller is what manages the pump. It tells it how fast to go and so on, and is what is managed and controlled by the physicians and staff who are responsible for the pump. And then there is a power source, whether it's batteries or a connection to a power source that's next to the patient and plugged into the wall. So that's typically what you see for most devices. Here's the HeartMate 2 again. What you see is that pump, which is just below the heart. You see a tube coming out of the left ventricle, which is on the right side of the diagram. And then you see the longer tube that reaches up to the aorta. So the pump is in line. It is sucking blood out of the left ventricle. It is moving blood up and through to the aorta. It's putting blood into the aorta on the other side of the aortic valves. So it's basically supplementing flow to the aorta and maintaining perfusion of the brain and other essential organs of the body. You see this patient's got a vest on with his 2 batteries that are hooked up to the controller, which is down there at the bottom. And you see the cables. You see the cables coming from the power source. You see the controller cable running from the controller through the abdominal wall and to the pump. Here it is more detail. This device has been approved by the FDA for bridge therapy as well as destination therapy. You will see controllers, or may see controllers that are external to the patient, but a device that's on a belt. There are also some newer models that have smaller controllers that can fit in the patient's pocket, so their device is not so obvious. You will see that patients have the power source. If they're at home, they may be plugged into a power source that is then plugged into the wall socket, or if you see patients who are ambulatory, you will see them with a vest on and having batteries. Typically, patients have 2 sets of batteries, so there's always one set that's on the patient and one set that's being charged. If you look at the pump itself, it's axial flow, meaning blood comes in at the intake. It runs through an impeller or a propeller-like device, which pushes it through the pump, and then it goes out through the tubing to go to the aorta. These pumps are more likely to cause shear stress on the blood and more likely to cause red blood cell breakdown or hemolysis. There's a newer HeartMate out there that you may see, which is in this diagram. The external devices look similar, but internally the intake to the pump goes directly into the ventricle. There is no big tube coming out of it, and then there's that other tube that's the outflow from the pump that goes from the pump to the aorta. If you look at the HeartMate 3 more closely, it also has 2 batteries. It's got a backup device and so on. It's got a controller. And if you look at it, it's really more of a spinning centrifugal flow pump. So there's no impeller in line with blood flow that can cause hemolysis. This device is supposed to cause less hemolysis. Which device your patient has, honestly, for most of us, we probably can't tell by looking at the patient externally, but the patient will know. The patient probably has identifying information with them, and the patient always has a family member or more who are the local experts on the device, and they can tell you the specifics about the device, and they can help problem solve for you. If we look at these devices, and again, we're talking about the HeartMate devices, but there are similar things with the other devices. We have the controller, which on the top left is the one that's typically worn on the belt. And then you have pocket controllers that might be used for the HeartMate 2 or the HeartMate 3, and they may look a little different. There's some type of power module that can be plugged in. There may be a portable power module, and then there's also possibility of batteries that can be plugged into the controller for power, and you'll find a charger. I expect that if you have a patient who's on batteries, they always have at least 2 sets of batteries available. So if one needs to be charged, the other is ready to go. Just talking a little bit about the Driveline. The Driveline is a cable that connects the pump to the controller. It goes through the skin. It is what you'll see as the wire that goes into the skin. It has 2 sets of wires. Everything is redundant, so there's 1 set of wires and then there's another set. So there are a total of 6 wires. 3 are the primary and 3 are the backup. So it's redundant system. You also see that there's some type of polyester that's woven around the cable at the skin insertion site, and that's to help the skin grow in and around the cable. The idea is to kind of seal the inside of the device, or the part of the device that's internal from the outside. So this polyester stimulates tissue growth so that there's a fusion between the connector or the driveline and the skin. And the idea is to keep germs from entering into the body. Just want to mention anticoagulation. All patients who are on LVADs, regardless of the manufacturer, are anticoagulated. Typically, they're on aspirin and Coumadin. These patients are high risk for bleeding, so you should have a low sensitivity to suspect bleeding with the patient. And we'll talk more about complications in a couple slides, but when the patients are anticoagulated, you always have to think about an occult GI bleed or even a massive GI bleed, or the risk for bleeding in the brain even with minor head injuries. So like all patients who are anticoagulated, if they have a head injury, we have a very low suspicion for head injury and bleeding, and we have a very low threshold to perform CT imaging of the brain in the emergency department. So if you have an LVAD patient or any patient who's anticoagulated with Coumadin with a head injury, they should be assessed by a physician in the emergency department because they probably are going to get a CT. The other comment about anticoagulation is these pumps are very sensitive to preload, meaning if the patient is volume depleted, the pump doesn't work well. So if the patient is having complications, think about hypovolemia from acute GI bleed as a complication of their anticoagulation. So again, very high suspicion of these complications for these LVAD patients. Talk about how we measure the mean arterial pressure. We need to generally use a Doppler to get a blood pressure on these patients. Some patients may maintain a pulse with an LVAD, and that's only because the heart itself has enough contractility to give enough of a pulse. But these devices themselves are non-pulsatile. It's continuous flow, there is no pulse. So we need to measure mean arterial pressure, if at all possible, which means we need to use a Doppler device, and you basically use a Doppler in the same way as you would use a stethoscope, but you're only going to hear one set of sounds. So if you inflate the cuff and then you deflate the cuff listening for return of pulse with the Doppler, as soon as you hear the swishing sound from the Doppler, that's their pulse, that's their mean arterial pressure, and typically we want them to be between 60 and 80. If the patient is critically ill and having problems, we'll take 50, but our goal is to be 60 to 80 millimeters of mercury. Automated blood pressure cuffs will not be accurate, so if you have a patient who's got an LVAD, you need to check the pressure with a manual blood pressure cuff and a Doppler if you have one in the truck. So you could also try using feeling for some resumption of a radial pulse, which may be a surrogate for the Doppler, although my preference would be to use a Doppler. So if you palpate the radial area, you drop the blood pressure cuff, and you start to feel something, then you might be able to count that as what their mean arterial pressure is. Again, I would go for the Doppler device. I want to talk a little bit about complications. There are acute complications and then some chronic ones. On the acute side, hypovolemia is a concern. So as I mentioned earlier, LVADs are preload dependent, meaning they are very dependent on getting adequate blood supply to the heart. So anything that results in problems with blood return or adequate intravascular volume, the LVADs are going to dysfunction. So if the patient loses blood, if the patient is dehydrated because of vomiting or diarrhea, if the patient is septic and they have dropped their peripheral pressures, all those things are forms of hypovolemia and loss of preload. So if you have a patient who's not doing well, think about fluid loss or dehydration or blood loss, and you should consider maybe a fluid bolus to see if it makes a difference. These patients are also afterload sensitive, so if they have a high resistance to outflow, they may also suffer. But for most of our patients, we have to worry about hypovolemia, whether it's due to sepsis, blood loss, dehydration, fluid loss, inadequate fluid intake. And these patients will probably be having a low flow alarm popping up on their device. Another acute complication is hemorrhage. Like I mentioned, patients can bleed heavily because of their anticoagulation. GI blood loss is the big one, trauma is the other. Patients are at risk for stroke, so because these devices are part of blood flow, they can cause clotting, which is why the patient is on anticoagulants. And if they do form clots in their pump, they can flip these clots and they can go to the brain, they can go to the peripheral organs, they can go to the extremities. So patients can have evidence of blood clots to the brain, which will result in stroke. They can have evidence of blood clots to the extremities, which will result in a cold, ischemic appearing limb, or it could go to the gut, where the patient could have severe abdominal pain. And typically, ischemic gut has pain that's out of proportion to exam. So they are very uncomfortable, but their belly doesn't seem very tender. These also are foreign bodies. These patients are at risk for infection and sepsis. Sometimes the pump gets infected and has to be replaced. I've had a couple LVAD patients who have infections, and they actually are on continuous infusion of intravenous antibiotics as a way of treating the infection and avoiding replacement of the pump. Sometimes the pumps themselves can become acutely occluded, and it can affect the pump parameters, and this can be a difficult problem. One of the most common causes of pump thrombus is either medication noncompliance, meaning the patient's not taking their anticoagulants, or there's been a temporary disconnect to the controller. The pump has no power, it shuts down, and clots start to form within the pump. So we have to think about pump thrombus resulting in low flow. And then sometimes there's trouble with the right ventricle doesn't function well. It's not pushing blood into the lungs through into the left side of the circulation into the left ventricle. This is something typically we will not see in the field. This is more likely something that's going to happen shortly after pump implant and will be identified and treated by the team that puts the pump in. But you have to think about the RV. So if the right ventricle is not functioning well, then there's a problem. One thing that could cause acute right ventricular dysfunction in your patients is pulmonary embolism. So think about, could your patients have had a PE resulting in chest pain, shortness of breath? The clot load to the lungs is so heavy that the patient has no flow through the lungs. Therefore, they have more or less right ventricular dysfunction. So think about that. Long-term complications, these are things that you're more likely to see in some patients. Just, thinking about it, 1 in 10 patients with an LVAD will have a stroke. 2 out of 10 patients will have some type of device-related infection. Typically, it has to do with the Driveline, which is why they've tried to get the Driveline to have tissue grow around it to prevent infection getting into it. But Driveline infections can be present, and that can require replacement of the Driveline. And then the caregivers are taught how to change the dressing daily using sterile technique. 2 to 3 patients in 10 will bleed. This can be life-threatening hemorrhage. So we have to think about that, again, because patients on anticoagulants have a low suspicion for blood loss. And I think it's reasonable to ask your LVAD patients if they've noticed a change in their stool color, if they now have maroon-colored stool and they're not feeling well and they appear to be hypotensive or in distress, they most likely will be suffering from a GI bleed. And you might consider giving them a fluid bolus to see if it makes a difference. Then about 1% of all patients with pumps will require replacement, either due to infection or due to clot. So getting on to more practical matters. What happens if you're called for an LVAD? What should you do? Well, LVAD patients always have a family member or caregiver who is also trained on how to use and problem solve the pump. They are your local experts. So always listen to the family members, ask them if they can problem solve the device, ask them if the device is working normally. The chances are by the time you arrive, they've talked with the LVAD coordinator or the LVAD team at the facility that placed the LVAD. So it's very important we communicate with family members. If the patient is unconscious, make sure you bring with them their backup controllers and extra batteries and so on, so that everything they need is at the hospital, particularly if you're taking the patient to a hospital or a hospital that is not the hospital that placed the pump. So if you're out in Fairfield County, Licking County, and you're going to take the patient to FMC or Licking Memorial, they may not, or they will not have what the patient needs to maintain the device. Bring everything with you and make sure that you document you bring it, and make sure you document who you left it with in case it gets lost. If the LVAD is alarming, make sure you check all the connections, make sure the batteries are charged and everything's tightly hooked up. And the reason for the alarm should be displayed on the controller. And again, family members are your local experts. I would let them manage the device before I would make any attempt to manage the device. They have been trained to the device and how to problem solve. So again, I know it's redundant, but use the family members as your resource. Sometimes you have to swap out the controller. I would do this with the input and support of the family member or the patient. If the patient is alarming and has got a red high priority alarm, they'll have to change to their backup controller. And if you have to do a change, the patient and their caregiver is the expert. I would let them do it. And what happens is you have to remove the controller from the Driveline, and then you're going to have to attach the new controller, the backup controller, to the Driveline. And this is only done in an emergency, and only should be done as quickly as possible. So I would do everything possible to minimize the exchange time on these devices. If the controller has been alarming with no power for an unknown period of time, then I would not make any attempt to change the controller. I would leave things as they are, particularly if the patient is awake. Because if this controller has been down, if there's been no power to the device, that means the device is shut down. And when the device is shut down, there's pooling of blood in the device, and there's opportunity for the device to form a clot, even with anticoagulation. So if you restart the device, you're at risk to then pumping these blood clots out through the circulation, resulting in stroke, resulting in ischemic gut, resulting in ischemic limbs. So it's one of those better of two evils, is to just leave it alone. So you get on scene, how do you assess the patient? So again, take a look at the patient. Remember that most common cause of acute LVAD failure is loss of power or failure of the Driveline. So do what you need to do with the family member, the local expert, to problem solve. And if you need to swap out to a new controller, if you need to put new power on, swap out the batteries, do that. Again, remember, LVAD patients typically have no pulse or an extremely reduced pulse. Take your stethoscope, listen over the pump. If the pump is operating, you should hear the whirling sound of this device. You need to do a manual blood pressure utilizing a Doppler, or attempting to radiate the radial pulse. So feel for the radial pulse. We like to see the mean arterial pressure between 60 and 80, 60 and 90. If the patient is not doing well, but the mean arterial pressure is between 50 or 60, I would not think about doing chest compressions. I might give the patient a fluid bolus just because they may need a little preload boost. O2 saturation may be difficult because of little or no pulse. The devices may not read it. Think about complications. Does the patient have any evidence of a nosebleed or a GI bleed? Any history or suggestion the patient may have had a head injury with formation of a subdural hematoma or epidural clot. Think about, is there any reason for right-sided heart failure, like pulmonary emboli? Could the patient be septic? If the patient is septic, then they might benefit from a fluid bolus to bring their pressure up. And again, remember, LVADs are extremely preload dependent and rely on right ventricular function, meaning there has to be an adequate blood supply to the right ventricle in order for the patient's device to work properly. So anything that reduces right ventricular filling or right ventricular function will have an adverse effect on the patient, reduce flow to the device, reduce cardiac output through the device, and the patient will decompensate. So think about sepsis, think about dehydration, think about uncontrolled hemorrhage, think about tachyarrhythmia. So if the patient is an SVT and they're hypotensive, they're just not getting enough return to the heart, you may need to think about cardioversion. That would be a tricky one, but you may need to cardiovert the patient, or you may need to give them some amiodarone or adenosine to try to get their heart rate under control. I think if you're looking at a tachyarrhythmia, I would think about giving a dose of amio before anything else, simply because amio is least likely to affect cardiac output. It's probably the safest thing you can do for the patient if they truly are tachycardic. Just a couple key points in terms of your patient assessment. A patient who's awake, alert, and talking normally is perfusing adequately. If the mean arterial pressure is greater than 50, they're going to be okay. End-tidal CO2 is another good thing. If the patient required intubation because of inadequate airway and their end-tidal is over 20, it's indicative of adequate output. If their end-tidal CO2 through their nasal cannula or through their mask is 30 or 40, they're having adequate output. In other words, they're putting out enough blood through the heart to perfuse the lungs, so there's oxygen exchange and there's CO2 exchange that can be then measured by your device. So capnography could be very important in these patients. So think about what I talked about a couple months ago with capnography and how perfusion to the lungs, good perfusion to lungs results in adequate CO2 output that you can detect with capnography. Some additional LVAD tips. Again, I can't overemphasize, let the patient or the caregiver lead. They are your local experts. And if transport is indicated, bring a caregiver along in case of assistance or their assistance is needed. Even in the world of COVID, if you have an LVAD patient, I would find a way to get the care provider to go with you for transport. This is one of the few exceptions we might have to limiting family members going with you to the hospital. Take the patient's emergency travel bag when you leave the scene. It's got the extra controller, it's got the batteries, it's got the contact information for the coordinator. You might even, depending on the circumstances, think about calling the coordinator and identifying yourself as an EMS provider on scene and asking advice from that person. If possible, take the patient to their hospital of record for any and all complaints. Emergency departments are not comfortable with LVADs. We see them, but we don't see them often enough, and we don't know how to problem solve. And I know I've talked to some of my friends at Ohio State. They do LVADs there. Even the staff and physicians in the ED, first thing to do when they see an LVAD patient is they call for the LVAD team. So try to get a patient back to their home hospital. I know sometimes that's not possible. If the device was implanted at the Cleveland Clinic, we're not driving to Cleveland. Depending on the resources availability in your community, you may need to take these patients to FMC or Licking Memorial. That's something you need to determine locally and probably know what you're going to do before you get the call. Make sure you watch out for the Driveline. So avoid kinking it. Be careful you don't twist it. Don't damage it when you're securing the patient on the cot. Be careful when you're cutting off clothes. You don't want to hit a power line. You don't want to hit the Driveline. So if you know the patient's got an LVAD, don't cut where you can't see if you have to cut at all. Keep the batteries in the controller in reach and keep them secured to the patient during transport. Keep the batteries in the controller dry. And again, keep in mind, end-tidal CO2 is a good measure of perfusion. So what happens if your patient's in arrest? Well, this is right out of our protocol. What happens if they're unstable? So, the protocol is driven based on whether or not the patient is awake or not and how you can assess the LVAD. So if the LVAD is running, you can hear the hum, and the patient is awake and alert, things are good, transport the patient. If the device is functioning and you can get some assessment, the patient's got an end-tidal CO2 that's adequate, and their mean arterial pressure is adequate even though they may be altered, transport the patient. If the patient's in an arrhythmia, I would probably leave it alone unless it seems to be significant. So, if the patient's in VF, you can shock them. But if there are some arrhythmias, the patient could be in an arrhythmia and still be awake. Patients could be in VTAC and still be awake. So, look at the patient, evaluate for hypoxia, check to see if there's any evidence of bleeding, check to see what their blood sugar is, and, treat the patient accordingly. If you have to do compressions, you can do CPR. Current recommendation is you do CPR if the patient is altered significantly, appears to be not perfusing, and is not responding to treatment. You can do CPR, but do not use the Lucas, do not use the autopulse. Use standard chest compressions. If you need to defibrillate the patient, you can do so, but just don't put the pads over the device. CPR is okay. I would have a low threshold to intubate these patients because I want to manage the airway, but I also want to see what their end-tidal CO2 is, because that will guide me in terms of my other interventions. So if the patient is unstable, I would perform BLS and ACLS procedures as indicated. Do what you can to maintain right ventricular filling. So if the patient needs a bolus of fluids, give them fluid bolus. If the patient's got a fever, if the patient's been vomiting, had diarrhea, seems to be bleeding, give the patient fluids, because it'll increase return to the right ventricle, to the left ventricle, and the device can work better. If you need to do compressions, you can do compressions, but don't use mechanical device. I do have a comment in about not for patients with total artificial heart. Those are extremely rare. That's where basically the heart is out and there's a mechanical device placed in the chest. It's not just in the science fiction movies. They do exist. Those patients we should not be doing chest compressions on. But any of the other devices, do chest compressions if they need it. And then defibrillate and cardiovert as you would normally. Just don't place the pads directly over the implanted device. So that's what I have on LVADs. I think I've covered all the bases. If not, please post questions on Workplace or send me an email. Otherwise, greatly appreciate your time and attention. Thank you.